Welcome, everyone. Good morning. Today is July 27th, 2025. I'm Jim Underdown, Executive Director here at the Center for Inquiry. Glad to see you all here today. I'm going to make a few announcements and then we'll bring our speaker up. By the way, we are recording today, so if you have like a super intimate or a private question or anything, let us know. And if you want to edit it out of the final project, we can do that. So just want to let you know about that. Let's see, some days in history. Tomorrow, the 14th Amendment was certified. That was a good one. Equal protection under the law, citizenship for African-American people. Tomorrow, I thought this was an interesting one. Tomorrow is also the anniversary. In 1945, a B-25 bomber flew into the Empire State Building. And it killed a bunch of people, but did not destroy the building. So what was the difference between the Empire State Building and 9/11 that destroyed both more modern buildings? Part of it, and we know this from a 20-year-old talk we had here with one of the engineers who investigated the 9/11 crashes, is the Empire State Building is a traditional core first skyscraper. The strength is in the core and it's supported by the core in the middle. The World Trade Center, the skin of the World Trade Center was weight bearing. So when that became compromised, you actually lost some of the support, and one of those, as soon as one floor collapsed, it just went all the way down. So don't say you never learned something at CFI. And also tomorrow marks the anniversary of the Olympic Games starting here in 1984. A few of you are old enough to remember that. Okay, all of you are old enough to remember that. Okay, so let's get to, two other quick things. First of all, I just got back from the Scopes anniversary conference. Yeah, it was really great. We were in Chattanooga, Tennessee. Hot as hell, people. Be so thankful you live in Los Angeles because we don't know what humidity is here. And there was something really cool about seeing one of the world's foremost evolutionary biologists stand in front of a statue of Clarence Darrow, who's got his finger out in front of the courthouse. The bad news is there's a sign on the outside of the building that says, "Read your Bible." It is a replica of a sign that was out there in 1925. And inside the courthouse, and I have pictures of it if anyone wants to see it, are posted the Ten Commandments. This is still a public building. It's no longer a courthouse, but it is still a public building, and I asked about what the hell was going on there. Okay, so, one last thing. The new Point of Inquiry podcast is out. I interviewed our friend and CFI fellow, Ed Krupp, who is the director of the Griffith Observatory. He's been there 50 years now. The observatory just turned 90, and I had a delightful conversation with him up in the observatory. He's in one of the windows that faces out over the basin, and he's still sharp as a tack, and it was really a delightful conversation. Okay, today, so it always struck me the kindness we show animals that are suffering. We're very willing to euthanize them, put them to sleep, and put them out of their misery. But when it comes to human beings, the philosophy changes, or has until fairly recently. Maybe Cara will talk about this a little bit, but I'm convinced part of that reasoning is that a religion, when I was growing up Catholic, you commit suicide, that's a mortal sin. There's no like gray zone or allowance for bad situations with suicide. So that, I think the sort of the mentality of a good chunk of the population is just knee jerk against this type of thing. So who better than Cara Santa Maria to talk about this? She is going to put a little bit more secular and science-based perspective on this. She's a clinical health psychologist, science communicator, podcaster, and Emmy Award-winning journalist. She got her Ph.D. in clinical psychology from Fielding Graduate University in 23. And her dissertation was about this very subject, so we're very lucky to have her. But it goes on. She's a great science communicator. She is a creator and host of the weekly science and social justice podcast, Talk Nerdy with Cara Santa Maria. She's a co-host, of course, in the Skeptic's Guide to the Universe and co-edited their recent release, Pseudoscience in Therapy, a Skeptical Field Guide. And she's been all over the media. She's been involved with a bunch of TV shows, including Brain Games, Explorer, Brain Surgery Live on National Geographic, Bill Nye Saves the World, all kinds of stuff. With all that, please welcome Dr. Cara Santa Maria.
Thank you. Okay, how does the mic sound? Good? Awesome. Okay. So this is great. I don't actually have to introduce myself now. As was mentioned, I worked as a public science communicator for the last 15, 20 years. I was a neuroscientist first, but never finished my PhD. And so in 2017, I decided to go back to school. I got my PhD, I think a few months before I turned 40. I was like, I'm going to get it in time. So I was by far the oldest student in my cohort, and it was. I'm glad I did it. The longer you wait, the harder it gets. I chose to focus my dissertation research on the topic of medical aid in dying. My clinical work, up until recently, when I was a fellow and working towards licensure. Now that I'm licensed, I'm actually working on credentialing to get back into my clinical work, is at Cedars-Sinai in the Cancer Center. And so and I tend to work more with end-of-life patients, or at least patients who are struggling with more advanced neoplasms. So it is an area of interest for me to talk about end-of-life planning and all of the options that are available for folks. And so today, I want to focus a little bit on what I learned in my research in medical aid in dying. This is a topic that I think can be really sensitive for some folks. I gave a similar talk when I was defending my dissertation in Florida at the Central Free Thought Society. I think that's what they're called. And there were some tears in the audience. So I do expect that that's okay and that's healthy and that's normal, but it's also, not everybody goes there. I'm going to leave some time for questions at the end. I think it's important to be able to dig deep. But I've divided my talk into two parts. I'm going to try and keep myself honest on time. The first half is sort of what we know about medical aid in dying, what's the state of the legislation, and just sort of answering some questions and helping to bust some myths. And then the second half are some of the insights that I gained when I interviewed 4 individuals and did these very deep dive interviews with them as they were navigating the process and then chose to die with medical aid. So that's more of a personal piece. Where possible, I focus on California as well. So, what we now call medical aid in dying, or you might hear me use the euphemism hastening death, is not new. It's something that we have evidence of, going back through almost every culture that's existed on the planet to ease suffering in the end. But historically, we would see documentation of these being private conversations, decisions that were made with families, with religious leaders, with communities. But only recently, this has become a legal ethical issue, right? So it's the purview of the state, it's the purview of medical professionals. You'll hear me use the word medical aid in dying a lot. It's often shortened to, I guess that's an acronym, not an initialism, to MAID. So medical aid in dying is the legally sanctioned act of taking prescribed medication to hasten death. And I'm going to focus on what it is and also what it's not, because I think that there are a lot of misunderstandings around the terminology. So you'll hear different things in the literature, medical assistance in dying, physician aid in dying, assisted death, death with dignity, the right to die. Here in California, the End of Life Option Act is the name of our legislation, so you'll often hear it called End of Life Options, or EOLA or EOLOA. What's important here, and you'll notice in that list, is that nothing says suicide. That said, when you dig into the literature, a lot of it says suicide, but that's usually because we're looking at older literature or literature from disciplines or countries where the more modern language is not in use. So we'll get into why, but pretty much across the board, experts in this area agree that medical aid in dying is ideologically distinct from suicide. It's also not euthanasia, and we'll talk about the difference between the two as well. So very often when you look at studies where people are asked with different types of terminology what they think about hastening death via suicide or hastening death via medical aid, they'll often judge suicide as negative, as isolated, as cowardly. They'll use different, very negatively valence words to describe it. But assisted death, when framed in that way, most people in the general public will use terms like painless, supportive, and accepted. We still have, obviously, as you probably know, a lot of critics and a lot of people pushing to try and reverse this legislation or prevent it from being passed in other states. And one of the main arguments that we hear a lot is that it somehow circumvents virtuous suffering, as if that's something that makes us, more, I don't know, deeper people, or like this is an easy way out. And until you have worked with people who are really, really suffering at the end of life, I just think that this kind of mentality shows a real lack of empathy and a lack of exposure to this experience. So this is a quote just by a clinical psychologist who also happens to be an ordained minister, where he basically says, I can tell you that those who that unequivocally, that there is no comparison between medical aid in dying and those who want to end their life prematurely via suicide. And that's a separate argument, what your thoughts and feelings are about suicide. I have thoughts and feelings that are quite different from most of the people within my profession. But that said, I have an ethical obligation to do everything I can to prevent suicide amongst patients that I work with. I do not have an ethical obligation to prevent medical aid in dying. I actually, facilitate it quite often. So stigma is obviously something that is rampant around this topic. In a Gallup poll, when they changed the wording just from physician-assisted suicide to physician-assisted death, the support went up significantly. So the language does matter when we talk about these things. Is that all I had on that slide? That's amazing. Oh, no. Huh. Oh, no, there it is. Okay. So because of that, we've seen changes in the wording across different professional organizations. The American Association of Suicidology, who studies suicide and how to prevent it, is like, this is not our deal. Like, we don't even deal with medical aid in dying because it's not suicide. So we don't have a statement on that. And then a lot of organizations like the APA, like I think the AMA, definitely the hospice organizations have stopped using the term like physician-assisted suicide or hastened suicide. Okay, so euthanasia is different from medical assistance in dying in that euthanasia, by definition, basically is the act takes place by the hand of the physician. That's the modern definition. So in MAID, a physician will write a prescription for a drug, but the individual has to ingest that drug themselves. In euthanasia, the practitioner can inject a lethal dose of medication. They can be the ones who actually induce death in the patient. And It is legal in several countries, but it's not legal here in the United States. So if you are interested in euthanasia, you won't be able to take that route legally living here in the US. It is legal in Canada, and actually, interestingly, just a tidbit, Canada is one of the only places in the world where nurse practitioners are also empowered to offer that lethal injection, and they do use injections in Canada. There are other forms in different countries. So let's focus on the US and specifically on California. There are 11 jurisdictions in the US where it's legal. It's actually 10 states and the District of Columbia, DC, so we always have to say jurisdictions. So that covers about 1 in 5 Americans. So the vast majority of people living in the US still don't have access. It just so happens that California is one of the states where it's legal, and we have a huge population. That's why we're looking at 1 in 5 with only 11 jurisdictions. So this is kind of the order that the legislation went into effect. So the very first law passed was in Oregon. That's why a lot of the early documentaries and a lot of the readings that you'll read are about Oregon. So in 1997, the law was passed by ballot initiative, and then, it was passed in 1994, and then it went into effect in 1997. After that, Washington followed suit, Washington State. That was 2009 via ballot initiative. The reason I put Montana in here separately is that Montana is a weird state in that there's no law on the books codifying or allowing for medical aid in dying, but there is a Supreme Court case, so there's precedent. A Supreme Court case said you can't block somebody's access to this. The rest of the states listed here all have legal access that is codified in the law, and this is the order in which those different laws were passed. Several states have laws on the ballot. Several states are always working to push this, but right now these are the only ones where it's legal. Okay, so every state is a little bit different. We'll focus on California in a second, but for the most part, we see this across all the different states. You have to be 18. You cannot be a child in the United States. You have to be a resident of that state, but that's not always the case. I think there are 1 or 2 states, I think Vermont might be one of them, where you can actually come in even if you didn't have previous residency. You have to be able to administer and ingest the medication yourself. So this does favor certain types of illnesses and end of life. That said, a lot of practitioners are very creative about how one can administer and ingest that drug themselves. It doesn't have to be orally, for example. It can be rectally, it can be via a PEG tube, it can be through a lot of different options. You also have to be deemed mentally competent. You have to have capacity to make medical decisions. There's always a concern in the legislation about coercion, even though there's like no evidence that that's something that happens. And then you have to have a prognosis of 6 months or less to die. Now, we could spend an hour just talking about prognostication because it is not an exact science by any stretch of the imagination. But reasonably, with no active medication that is utilized to extend your life, you should be thought or deemed to die without intervention within 6 months due to the disease that you're facing. This is the same legal requirement for hospice. And then several states require verbal and written requests that are initiated by the patient, which bums me out. So several states, the patient has to bring it to their physician. Several states require that 2 different physicians certify. And this was a big deal early on in the legislation, a 15-day wait period. And we found time and time again that people were dying during the wait period because they couldn't get the meds in time. So these safeguards that, on paper seem like they're preventing coercion, they're protecting vulnerable people, actually often put undue burden on vulnerable people. So because of that, in California, there's been an update to the law. In 2022, the wait period was reduced from 15 days to 48 hours. So now it's only 2 days between your requests, and you can move forward quickly. Now, that said, you often don't get meds in hand the next day. They have to come from a compounding pharmacy. It can still be a complicated process, and I always encourage patients to start early with their planning. But in California, we pretty much follow the rules that I mentioned before. You've got to be 18. You have to be a resident, but there's no time span, so get here quick. You have to have a diagnosis that says that you will die within 6 months. You have to be able to make medical decisions by yourself. It says determined by 2 physicians, which I love that about the California law. I wish it was 1. But in Hawaii, it has to be a mental health provider like myself, which again is another undue burden. Your doctor knows your capacity, right? If you've been working with a physician, you have a primary care who's going to write this, they know what you think and feel because they've been working with you for so long. So I don't think a mental health professional needs to come in unless there's a concern about capacity. And so you can see here that they even define, you have to be able to self-administer either by mouth or through a peg or a rectal tube. So there's a lot of different kind of creative ways. And like pushing a button, that's still self-administration, even if you're not strong and, can rig things up. Oh, I'm going backward. Okay. So this is an older Gallup poll. We have newer data, but it didn't have pretty graphs, so I included some of the older ones too. Most Americans support this, especially when it's worded in a way that doesn't make it sound like suicide. But as expected, people on the left support it more than people on the right. This is an interesting one, and we'll dive into it, but we do tend to see that people of color support it less. We also tend to see, obviously, this is a big one, right? The nuns have much larger support than the religious folk, but the religious folks' support is still pretty high. And so I think that's an interesting point. I think it's easy to perseverate on the idea that like it's all about religion. That's why we don't have more access to this. It's not. It's a part of it, but it's a much more complicated story than that. This is updated from last year. So here, by religiosity, we want to know, is it morally acceptable? Is it wrong? The problem is Gallup continues to use the term doctor-assisted suicide. So I know that these numbers are somewhat biased. But you can see that people who seldom or never attend religious or have religious attendance, and those who identify as having no religious identity are much more in support than those who don't. But again, like, half of Catholics over here saying it's morally wrong, less than half, and most of them don't know, but still almost half saying that it's okay using the word physician-assisted suicide. I think that shows you a lot. Okay, so who chooses it? Well, here are the demographics. The 2024 numbers just recently came in and they published their report. So last year in California, 1,566 individuals made verbal requests. Of that, and this is really out of step with the literature that I even saw when I was writing my dissertation. Usually we were looking at 2/3 or less actually getting the script, because very often people would come to their doctors and say, I want to explore this, and then they might choose not to go that route. They might choose hospice or better palliative care or antidepressants or a different approach to coping with what they were dealing with in end of life. But I think we're starting to see that with education, the people who know that they want it are going, they're asking, and they're getting the script. So the vast majority of them did receive the script. 63% of them died via MAID in 2024. So these are year total. So it's in 2024, 1,566 said, I want to do this. 982 did this. That said, we don't know about 388 because the reporting didn't come in. So they may have done it also, or they may have died from the illness before they could, or they may still be alive. There's also an additional 50, this is just confusing for the numbers, who died this year but got their prescription last year, and so that biases the numbers. So it's 1,032 MAID deaths total in California this year. There were 283,824 overall deaths. So 0.36% of people who died in California died with medical aid and dying. Most people do not choose this option. Most people are not eligible for this option. This is not an epidemic. And so I think it's important to remember that. We would like to see that number go up if it prevents some of these people from having undue suffering, and if it's what they want. But I worry that some of those people didn't know they could. or they were somehow prevented from, barred from access. So we'll talk about that too. Okay, I mentioned before the legislation does tend to favor those who die from cancer because cancer illnesses tend to be slower. There tend to be medications that can prevent or lengthen the time between when you're diagnosed and when you die. And so more conversations can be had. That's not always the case, but that tends to be the case more than things like cardiovascular, neuro, respiratory, and others. One of the big problems with medical aid in dying being a capacity question is specifically neurological diseases that have a cognitive component. So there's a really tough spot that a lot of people find themselves in with diagnoses like Alzheimer's or Lewy body dementia or even Parkinson's, where individuals may know that this is the choice that they want. They want to wait until they're so sick that they don't want to live like that anymore, but there's a point at which they won't be able to do it because they no longer have capacity. So it's a tough thing to decide to hasten your death while you're still lucid, while you still have that time that you want left, but it's a calculus that, you know, a lot of people have to make for themselves. Okay, why do people choose MAID? Well, existential suffering by like far and away is the biggest reason that's self-reported. So what is existential suffering? It's kind of a vague term. And I should have mentioned at the beginning, I'm trained as an existential psychologist. So my academic training and then my clinical work is in using themes from existential philosophy and then existential practitioners. So, you know, you've got like Camus and Kant and Sartre and all of these like philosophers that you read. And then practitioners like Irv Yalom, like Merleau-Ponty, like these different individuals who utilize existential principles, individuality, fear of death, loneliness, meaning-making, freedom, responsibility. And that's the type of work that I do with patients, is try and find those areas in themselves that they're struggling with and look for sources of empowerment and sources of meaning. I do some CBT work as well, and if you have questions about that, we can get into it. But existential concerns is my deep interest area, and so I do tend to be biased to talking about them. This is why this is an area that I really like working in, because existential concerns are most people's reason that they seek MAID. Okay, so what does that mean? Well, for a lot of people, they say living like this sounds worse for me than death. I'm at that point in my calculus, and that's an important point to be able to identify. Impairment, indignity, pain, while it is there, we will get to that in a second. Hopelessness, helplessness, burden, tiring of life, low quality of life, fears about the future, loss of autonomy, loss of identity, loss of the sense of self, fear. Very often in hospital, one of the things I struggle with as a mental health provider is getting a call for a suicide assessment on an older individual who's diagnosed with stage 4 cancer, who is rapidly declining and who is starting to talk about death a lot. And I'm always trying to educate physicians the difference between suicide and end-of-life planning, and the types of things that come up, the types of things that they hear in the room when they should call for a mental health practitioner to do a suicide assessment, or maybe myself or a social worker to start talking about what's coming up for them. Start talking about, if they haven't already, an advance directive and a POLST and what these plans are, and maybe even hospice. Okay, so let's talk about pain. By and large, when you ask most people who haven't done the work in this area, and when you ask most physicians, they're going to tell you, why do people choose medical aid in dying? Because they're in unbearable pain, and they don't want to suffer anymore with that physical pain. But even though that's often listed, it's usually pretty low on the list for people. Usually existential concerns are higher, like burden or growing weary of life. MAID can eliminate suffering, physical suffering, but it can also increase or buffer against existential suffering, because it can be that last thing that is your choice and your choice alone. And you'll hear me use terms like death day choreography a lot. I stole that from a researcher, a sociologist named Mara Buchbinder, who wrote a beautiful book about called scripting death, about planning your death the same way you might plan your wedding, the same way you might plan a birthday party, and really taking that power back and making those decisions that are really meaningful for you and your loved ones. Okay, so another big theme that you see a lot in the literature is a sense of control. We mentioned having power over the circumstance. I want to die when I want to die, how I want to die. Very often that means dying at home. The vast majority of people would prefer to die at home than in a hospital. But the vast majority of people end up dying in the hospital, which is not the way we like to see it. Do you know what the average stay in hospice is? And hospice is a 6-month benefit. The average stay, meaning from the time that they elect for hospice and then they die on hospice, is 8 days. 8 days. Because so many people wait so long. Because there's this fear that once I say hospice, that's it. I'm done. I stopped fighting. But very often people can live out really good days when they've no longer, when they've stopped taking their chemotherapy or stopped taking the medications that are extending their life, and they've started utilizing good palliative care to be able to be alert during the day, to be able to enjoy the things that they want to enjoy and live out those days much more comfortably. But very often we wait. And so I'm all about hospice education early. And definitely palliative care. I'm just going to say this outright. If you are diagnosed with cancer, ask for a palliative consult. It doesn't mean, and it has nothing to do with death. The word to palliate is to reduce suffering. Palliative care doctors are just experts in pain management and like sleep and alertness during the day, just quality of life. You should, if you have a serious illness, you should always work with palliative. It has nothing to do with end of life. So don't let that term, we've even changed the name at Cedars in my department in cancer to supportive care medicine, to stop scaring people away from getting the help that they need. This, I think, is an interesting philosophical. I can't spend too much time on it, but I pose to you rhetorically to grapple with this question. We have a tendency, it's a cognitive bias, to choose to shy away from active choices in some respects when we're afraid they have negative consequences, or to choose active choices in some respects when we think they'll have positive consequences. A good example of this was the COVID jab. A lot of people were anti the COVID vaccine, not because they were anti-vaxxers or they had been, reading up on Wakefield, but because they were afraid of doing something active and causing harm. And they figured in their mind, if I just don't do something, then the calculus is less harm. And they forget that not doing something is still a choice and it still has a risk analysis connected to it. That's the case here as well. So a lot of people may say, I don't want to actively hasten my death because that could have all these negative consequences. But choosing a, quote, natural death, for some people may have stronger negative consequences. And so it's always a risk-benefit analysis. So yeah, like, are we keeping people alive against their will? Is that not a way to frame it so that we see that as an active choice? Right? We do it with our pets. All right. Families of MAID patients, generally speaking, are very in tune with the reasons that their loved ones choose MAID. They're showing up, they're listening, and when you survey them after the fact, their answers match those with those of the patients themselves. Providers, far less so. When you ask them, they're like, it's pain, it's all about pain. We just got to help them with their pain and they won't need to do this, which is a huge bummer because it's just not the case. We don't have good medicine for existential pain, right? It just doesn't exist. Also, a lot of physicians just aren't educated on this topic. They kind of don't want to come near it because they are worried about like a CYA thing. It's like, oh, how much liability is there in that? So here's a great study that showed that 60% of physicians, this was a representative sample, it might not have even been that good. The number could be higher now, who said that they favored MAID. Of them, only 13% were like, I'll actually be involved in it. That's problematic, right, for access. MAID overwhelmingly does occur in hospice, and so we're seeing more and more education in hospice providers, which is great. Suicide is still a problem in hospice. Access to MAID prevents suicides. It does, and that's important to remember. And I talked about palliative already. Palliative is your friend. Okay. I was asked earlier about conscientious objection. So legally within, I think, every state's law, there is a clause for conscientious objection. No physician shall be compelled to write a MAID prescription if they deem it as something that's outside of their competence or something that they think is morally, wrong. They can always refuse on personal or professional ethical grounds. You would think most of them refuse because of religion. And some of them say that that is why. But a lot of them say that it's inconsistent with first do no harm, which sort of on its surface, right? But again, let's dig deeper into that philosophical question of, is doing nothing also a choice? Some say, obviously, they think it's immoral or it's against their religion, but the majority of people say, I don't want to deal with how I will feel afterward. I don't think I could handle being a hand in this. So that's a really interesting perspective. And I think it goes to show the need for more mental health support among our physicians. So this is a dilemma for rural patients. It's a dilemma for patients who live in places where it's legal, but they still can't find somebody willing to write the prescription. Or, who else can object? A pharmacist. So maybe they get the prescription, they can't find a pharmacist to fill it. So this can be really problematic because it's not uphill. We can get into this. I don't actually include it in my talk, but it's a lot of it's like grams and grams of medication. It's a big mixture of, it's like DDMP, I'm not a pharmacist, so it's like amitriptyline, digoxin, there's a handful of different drugs that stop the heart, that slow respiration, that are anxiolytic, and they're all mixed together as a powder that you mix with water. So you have to be able to drink a fair amount of liquid, and it's quite bitter and disgusting. And so we've got some hacks for how to make it a little bit easier to go down. So this is a bummer, but things are getting better. I just don't have a more updated statistic. In 2019, of 270 California hospitals that were surveyed, 61% of them were like, nope, not allowed here. And very often that is because the hospital has a religious mandate. Yeah. Okay, social justice and diversity. I think this is the last of it before I get into my research. Let me see how I'm doing on time. 11:45. So we want to open up for questions when? Like 12? Oh, okay. That sucks. Okay, I'll try and speed through. So the vast majority of MAID patients are white, educated, insured. It tracks with the vast majority of people who use hospice benefit through Medicare. California, by far, is the most diverse state with access. 87% of last year's participants were white. And I can promise you 80% of people in California are not white. So what's going on here? While it is true that there are cultural factors, religion, community values that do come into play, access is still a problem. Also, we know that folks who have been historically disenfranchised and those folks who have been living in poverty are diagnosed with their illnesses later in the disease course, and they have less time to have these conversations. So this is also a function of inequity in the healthcare system overall. And an additional barrier, these drugs are not covered by Medicare. This is Medicare's federal, right? Federal government is not going to pay for this, especially not now. So a lot of people are paying for these things out of pocket, and it can be like thousands, plural, of dollars just for that prescription. And that can be really hard for some folks. Okay, so we talked about that already, but we need to remember that to ignore the privilege of choice and death, if we are, individuals within the sort of privileged class, is to kind of erase a lot of social inequity. We didn't start at a level playing field. It took a lot of time for us to get where we are right now. Okay, so I was going to open up for questions about that before I talk about my research, but if you have questions about that, I want you to remember them because we're going to switch gears a little bit. Okay, so this is a quote of mine from my dissertation research, because how tacky to quote yourself. But this is sort of I don't know. I think it captures my thoughts and my mentality as I was digging into this research. So from an existential perspective, death is a solitary occurrence. Nobody can take one's place in death. We live our own lives as we die our own deaths. In other words, and you'll hear this a lot with existential philosophers, nobody can die your death for you. You have to face it. Doesn't mean you won't have support, but you have to face it on your own. But a unique aspect of medical aid in dying is its potential for careful planning and implementation. A well-scripted death is at the heart of many requests. Such death day choreography often involves the dying individual's family and friends. They are perhaps the closest available ethnographers, aside from the patient themselves, providing support, comfort, and care until the end. And this is something that I really discovered as I was digging deep into working with these individuals. So I spoke with 4 people over the course of a couple of years. They were all dying of life-limiting illnesses. They were all living in California. It was 2 men, 2 women. The youngest was 34. The oldest was 84. 3 of them have died since then. 1 of them is unknown, and I'll talk to you about how I know about this soon as I talk about the individual participants, because one of them is like really near and dear to my heart. So participant 1 was a 79-year-old white woman. She was single, she had no children. She was culturally Jewish, but identified as not religious. She had been living with MS for a very, very long time. She was bedbound and incontinent, and her quality of life was very low at that point. She was also a clinical psychologist working with cancer patients. So she was really interesting. She was like, I want to help you with the research. It was so hard for me to find participants. I was like, thank you. And she was really, really funny, bitingly funny, but in a lot of ways very much alone. She had, not to disclose too much, but she had kind of distant-y family, but she also had quite a lot of money, and she didn't want them involved because she was worried about their intentions. And she ended up leaving her entire estate to her housekeeper. Yeah, and her housekeeper was there for her. She started as her housekeeper and really became her caretaker. Was very religious, was Latina, was very religious and was afraid to be present, but at the end decided, I don't want you to do this alone, and stayed with her. She also took her cat, which was a really big deal to her. So I interviewed her on December 13th and December 23rd, 2021, and she died on December 25th, 2021. Now, anybody who looks at that date is like, oh, okay, that's an interesting day to die. And I asked her about that, and I didn't want to bias her. I was like, is there anything about December 25th? And she literally said, honey, I'm a Jew. Everyone will be gone. No one will notice. Like, that was her entire, and I was like, okay, all right, that's great. So she was lovely. She died very soon after, and she had a death doula who I knew. And so her death doula got in touch with me and shared how it went, and so I got a lot of really lovely feedback per her permission. When I asked her why she wanted to be involved, and I think I already said this, she was excited that she could have some sort of input about the future from a psychological perspective. Participant 2, 84-year-old woman. She was widowed and she had no children. She described herself as a fallen away Catholic, and so a lot of themes with her were around suicide, and it was really interesting to dive deep into that. She was diagnosed with stage 4 colon cancer in October of 2020. She also had lost her vision due to macular degeneration. When she was working still many years before, she was the director of nursing and a hospital consultant. So she was intimately aware or intimately, I guess, involved in sort of the medical world. I interviewed her in January and June, so I had quite a bit of time in between of 2022, and she didn't follow up, and I had no way of knowing. But my assumption is that she either took the medication or she has died since then because of her disease course. So this is a long quote from her, but basically she went through a lot. She didn't know she had legal access. It was really frustrating for her, and she had a lot of frustration around that. And so when I asked her why she wanted to be involved, she was like, I want this to be easier for other people. It should not be this hard. Participant 3, very near and dear to my heart, a very, very young man. Single, no children, identified as atheist, GBM, so a pretty horrific diagnosis, brain cancer. In July 2021, he had been living with it for quite some time. So July 2021 to December 2020, and then May 2023 is a long time to live with GBM. He actually didn't choose to take his medication until February of this year, and he invited me to be present at his death. And so it was myself and his immediate family, and it was just like a really obviously emotional experience, and I learned a lot from it. He had a lot of anger, and one of the things that he was really struggling with was the early question of why me, which a lot of people struggle with. But one of the things he would say over and over, which I take to heart and I often share with my other patients, is deserve has nothing to do with it. Yeah. And then finally, 78-year-old man, widowed with 2 children who were present and who I got to talk to as well. He's somewhere between agnostic and atheist, but definitely secular. He was diagnosed with intestinal cancer in 2015, and then it recurred in 2020. He was a lecturer. I interviewed him. So if you notice, he retired right before I interviewed him. He just kept working till he absolutely couldn't anymore. And he died the day after I interviewed him. He had intended, after the second interview in June 13, he had intended to wait a few more weeks, but he had the medication and he started to feel like he was declining. So when I called him that day for our interview, he was like, I'm going to do it tonight. And I was like, we don't have to do this. And he was like, no, I think it's important. So he really did, it was deeply meaningful that he shared time with me, this person he doesn't know, on the last day of his life. So when I asked him, I really liked his quote, so I'll just read it in full. I know my mic is over here. So I realized that this is the kind of decision that not everybody's going to make, and that I really feel that I may be able to give a perspective so that people can be helped in making this decision. I think it's important to maintain control of your life and death, and that if I can help you give more information to people to make an informed decision, I think that's important. So you can tell that a lot of people had this found meaning in sharing their stories so that other people could have access. And I really appreciated that. So this is just all of that summarized. This is all the stuff you have to include in a dissertation. These are the questions I asked them. We won't dive into that, but it was a semi-structured interview, meaning I wanted to make sure to hit all of these questions, but a lot of follow-ups came up, a lot of things that were personal to them. So this was just the starting point. I'm not going to get into the philosophy stuff because this is wonky and we don't have time, but this is it's a qualitative study that I did, not a quantitative study, which when I was a neuroscientist first, I didn't even know existed. And so I was very used to hard statistics and hard data, objective data. And then I was like, oh no, there's all this weird subjective stuff. But I learned how to do hermeneutics. It's Heideggerian and Husserlian, and but we don't have to get into that. 2 things that are very big existential, philosophical, and practical concepts that I grapple with in my work that came up a lot, so I wrote about them a lot, is this concept of the boundary experience. So you'll hear that term sometimes when you read wonky literature on this, but very often existentialists describe there being 2 modes of existence in life. All of us are living in one of 2 modes. We're either in something that they call forgetfulness of being, which is capitalism and going to the movies and having a chat about the weather. And then there's the ontological mode, or mindfulness of being. You almost get in a car wreck and you recognize really quickly how precious your life is. Somebody gets a diagnosis. You watch a really beautiful film and a lot of things come up for you. And all of a sudden you're thinking very existentially, and you're thinking about your lifespan, and you're thinking the big picture questions. We can't live in that mode all the time. It would be too threatening and too stressful. I think a lot of us are practicing going into it a lot more often than maybe those who don't want to think about those things, but we keep falling into forgetfulness. The boundary experience is the thing that knocks you into mindfulness of being, right? And so the boundary experience for my participants was their diagnosis, or the advancement or the recurrence of their disease, or the loss of certain capacities, like I can no longer walk, or I can no longer go to the bathroom on my own. There are multiple boundary experience. So yeah, you can see that. Crisis of faith, that's a big one. Lots of people like to talk about that. So I didn't pull this out as a theme in my research, because my research is to find themes in what people said and identify them and label them. I never called this a theme because it was there in everything. And so I kind of referred to it as the water that everybody was swimming in, the background, right? So like I'll often talk in other social justice circles about white supremacy or about patriarchy. This is the water we always swim in. It's always there, and you can constantly find examples of it, but you can also sort of ignore it or forget it if you have that privilege. Okay, so this is how I did my research. It's just I interviewed them, I wrote things down, I blah, blah, blah. And then I pulled out what are called constituent themes. So I pulled out constituents. So these were things that were directly related to medical aid in dying that they said. And then I looked through them to see if there were themes coming up. So there were 477 total constituents, whatever, it doesn't matter. And then I came up with 22 different themes. So the rest of my slides are the 22 themes and then the 4 overarching themes that came from the 22 themes. So I'm gonna fly through the next 22, because I don't think it's necessary to go through them in detail. But what I did in my dissertation, if you're ever interested, and what I have in these slides are things like, okay, I'm just gonna pick one at random. Like we talked about suicide, so I think that would be a really good one. 14, grappling with suicide. That was a theme that all of the patients struggled with. So what I would do is I would pull quotes from the patients that really evoked that theme. So this is directly from their mouths. So here's 2 different patients. Patient 1, if you remember, the secular Jewish woman. Then I thought about, well, maybe I'll just go down to, and I mean, this was California. I redacted this for the paper, but she said Alameda. I'll go down to Alameda Street and look for a drug dealer and get some really heavy stuff, like a massive dose of heroin or something. And I thought, oh, Jesus, this is becoming like a bad comedy, like gallows humor. So I decided, no, I'm not going to do that. So she was really concerned before she recognized, because she did not know MS would make her eligible. Because she's like, I've been living with this forever. There's no way. But it did. And then patient 2, this was the fallen Catholic, but who still had a lot of these strong convictions. If I take the medications as provided, then I'm committing suicide. She was standing by that. And it was not my job to educate her to the contrary in this portion of the research. I was just learning from her. And suicide is against Catholicism. So that was another hurdle for me to get over, so to speak. I am a firm believer in the fact that if there is a God, God doesn't want us to suffer, and pain would be suffering. And therefore, anything I can do to help myself not suffer would be good. When push comes to shove, the individual who has to mix up the powder and drink the potion is committing suicide. No, I don't see any difference. So for her, she saw it as still a sin, but she believed that God is good, and that even though she would be sinning, God would prefer her not to suffer. So she was sitting with both of those things and really struggling with that dichotomy. Okay, so I have a lot of different, themes, but then at the very end of it, I came up with 4 comprehensive things that I believed encompass these 22 themes. So medical aid in dying, number 1, offers the choice and empowerment to end life on your own terms. We talked about that a lot at the beginning. Number 2, necessitates acceptance of death. Nobody is going to engage in medical aid in dying unless they've done the work and grappled and chosen or realized that they are going to die. I have worked with patients who were talking right up to the end, who are like, if we just get this one medication. Like I've been in the hospital next to patients who were like asking for things because they literally thought that they could stave it off. They were just in abject denial that it was happening, and that was their authentic way of dying. People who choose medical aid in dying are not doing that. They know what's coming, and they know that it's going to be hard, and so hard that they don't want to go through it, and so they'd rather do it now. So I call that, or I don't, a lot of people call that the immortality salience. It's an awareness of your own death, of your own demise. Medical aid in dying palliates physical, psychological, and/or existential suffering, so all of that together. And medical aid in dying occurs in a social context involving friends, family, and/or chosen family, which is a theme I didn't really expect to see going in. And that's where that quote I pulled, really grapples with that. So here you can see just how I laid out all the different constituents and which ones are subsumed within which one. So then last and finally, before questions, I'm just going to read 4 quotes from my participants that I think encompass these themes really well. So again, participant 1, the wonderful secular Jewish woman, choice and empowerment death. I don't want to die. I don't see that as a good way to leave this world, but everybody has to leave this world. And under the circumstances, leaving on my own terms is the best option. I wish I had more healthy years. I feel that had MS not entered my life, given my family health history, I probably would have lived well into my 90s. But do I want to live into my 90s with my physical condition being what it is? Absolutely not. Mortality salience. Participant 2, who is the lapsed Catholic. I'm trying to help as many others as I can, you included, to be of support to other people who are dying and know that they're going to die. Personally, I feel very fortunate that I know I'm going to die. All of us know that, but none of us know the time period. My time period is relatively limited, and I don't know how long I'm going to live, but I want to live until I die. So remember, she had stage 4 cancer. Palliation of suffering. So here is the ex-kinesiology lecturer who had the 2 adult children present with him when he died, who died the day after I interviewed him. My wife was diagnosed with uterine cancer, and she went very quickly. She went in the hospital. It dragged out. I know that sounds contradictory, but what he means is she died soon after she was diagnosed, but her actual death was days in the hospital, and it was really painful. My mother had COPD, and hers dragged out for years, where she became irritated and hard to deal with. And I understand why, but it wasn't a condition that I wanted to put on anybody. I didn't want to be in significant pain for a long period of time. I figured if that was my future, I didn't want it. He didn't want to do that to his children or to himself. And finally, dying in a social context. So this is the glioblastoma young man. He really grappled with wanting to die alone. A big thing he kept saying to me over and over, especially in our first interview, was, I don't want anybody there. I don't want my family there. Now, if you remember, he invited me to be there. He also invited some of his friends. They showed up to say goodbye, but they weren't comfortable staying for the death, and they left. So it was his father, his mother, his sister, and me, who had only met him once, who had spoken to him a few times, texted a few times. So when I was like, what's going on? What do you think you want to do? This is earlier. This is years earlier. He said, I think they want to be with me. And it seemed like that was the play in the documentary I watched. The whole family would be it was almost a ceremony of just saying goodbye. And both the kids they interviewed afterward, they felt good about it. They felt lucky that they were able to be there with her when she went. And it didn't go in a lot of pain, because I watched 4 people go in serious discomfort. And my whole family, it was so bad that we promised each other that that wouldn't happen to us. Not everybody has a relationship with their family like I have. So I was going to say, because this was when I asked him, do you have any advice for other people who are choosing this path? So I was going to say, keep your family close, and they're the most important thing, because at the end, they're the ones that will be there, but that's not the case for everybody. So if I engage with this research further or collaborate with others, I would like to talk more to friends and family, not just the individuals. I'd like to see why some people are interested in MAID early on before anything goes south. I'd like to see the perspectives of those who want to use MAID to have legal access. I'd like to use some more statistical stuff. Blah, 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 not important. Okay, and then I have some resources for you guys. This used to be called the American Clinicians Academy on Medical Aid and Dying. They recently changed the name to the Academy of Aid and Dying Medicine. So Academy of Aid and Dying Medicine, aadm.org. But if you do acamaid.org, it still forwards to them. They wrote a really great short book called Medical Aid and Dying that gives you soup to nuts, like how to mix the meds, like what the day is like, what kind of resources you can have. It's really, really helpful. I gave this book to the young man, and it really helped his family through that day. Some other organizations you may donate to or you may be involved with: Compassion and Choices and Death with Dignity. And then I have a bunch of references, like whatever. That's just proving that I did my work. And then, yeah, let's open it up for questions. And maybe, yeah, we can have lights. And what time do we absolutely have a hard out? Oh, sorry. Thank you.
No hard out. We own the building.
Oh, great. So I know some of you have to go. You mentioned earlier. Hopefully I answered a lot of your questions. If not, maybe we can figure out how to be in touch. Of course.
If you have a question, raise your hand and I'll get you a microphone right here. Yeah, sure.
Just the countries you mentioned that with euthanasia. What about Switzerland? You mentioned Belgium. We come from Belgium, and I thought Switzerland was on that list, but it wasn't on.
I'm not. I should actually look into that because, yeah, everything that I've looked at doesn't show Switzerland. Maybe it's not like a legal codification there. Like there are other countries where they've done it, but they had to get like a court injunction and then they did it. So I'm not sure what the rules are in Switzerland, but almost across the board, I don't see it always listed as like a place where it's fully legally sanctioned. So it could be that they sometimes do it. I know the Netherlands is sort of the place everybody talks about going to.
And his father at the end wanted suicide. It's not allowed in, euthanasia is not allowed in Italy. And he wanted to go to Switzerland.
Yeah.
And I remember at the time that we knew about clinics that accepted people from Italy. So it would be interesting. And we lived in Belgium, so it was.
And it could be, too, that there are places where it's not necessarily legal, but it's not necessarily punished. And so it just kind of happened, kind of like how marijuana was for a long time here or like in Amsterdam, it's like,
Thank you for the excellent presentation.
Thank you.
Okay, question back here first.
Hi, Cara. One thing that I didn't see touched on is, are there instances that this goes wrong and the person doesn't die after taking the dosage? And
what do you do in that situation?
Yes, exactly.
So I keep up with the literature because I'm a member of the academy, and so I'm on the listserv. And I'm not a physician, so a lot of the published data is a little above my understanding and my pay grade. But from what I understand, I don't think I've ever seen a single case where somebody didn't die. I think what we keep statistics on heavily is time from ingestion to death. So I don't like using the term go wrong, but the times when it's outside of a normative death and it's what we're trying to avoid and improve our approaches is when the death time is longer than like 5 hours. Usually what will happen is the individual will take the medications and within 5 to 30 minutes, they'll be unconscious. And then the death itself can take 1 hour, 2 hours, but in some extreme cases, usually because of gut absorption issues or other medical complications, it could take over 24 hours for them to finally expire. But I don't think I've ever read anything where the person was conscious through any of that, because the drugs are they do slow your heart to a point where it's incompatible with life. And so it's just a slow, quiet, agonal breathing, but the person is not awake. The death that I attended, it was similar in that he was young, which is already difficult. Like your body fights when you're that young. He also had GBM, and for some reason it does seem to be the case, but we still don't know why. And people are actively writing about it right now that brain cancers are inversely correlated with longer death times. He also was on very high doses of pain medication already, so he was using fentanyl patches regularly. And so a lot of the opiates in the drugs weren't touching him the way that they would somebody who was opiate naive. And so he was alert for like 30 to 40 minutes after he took the meds. He got up and walked to another room after taking a lethal dose of medication. And finally, when he fell asleep, it was several hours to death, but there was oh my goodness. And part of the concern that we had, and this is the thing that most people want to avoid, the medication burns. It's the amitriptyline in the medication, it burns when it goes down. And so very often it's recommended to keep sorbet close by to help with that burning sensation and the bitter taste. He took about half of it and started panicking, and he was like, I can't finish it. And luckily, the family stayed very calm, and we talked him through it, and we were like, you know you can't only take half of this. You do not want to have the outcome that would happen if you do not die from this, because this is very dangerous. These are lethal drugs, right? And there could be permanent, like, if you don't like how you were living before. And it was really hard for him, and he took some deep breaths, but he ultimately was able to get it down. But there is, for most people, they say you need to be able to drink all of it within like 90 seconds, because you might fall asleep, and you don't want to fall asleep before you finish it. He would have been fine. Like, he had time, but we didn't know that. Right. Yeah.
You'd think with all the research they've done on prisoner executions that they could get something a little more.
But that's straight into the vein, and that's not legal.
Oh, okay, that's why, because
Yeah.
they still have to do it themselves. Okay,
Yeah.
yeah, question over here.
Hello, how are you, doctor?
Good.
I was concerned about a situation I had occur some years ago. I had a friend of mine who, well, we use the term suicide by means of a firearm. And what happened was, pardon me,
Of course.
I did not understand the mental issues.
Yeah.
I was the last to talk to him 2 weeks before he committed autodestruct. That's what we referred to it as.
Yeah.
And that's exactly what it was.
Yeah.
But he was in fine physical health. He was a superb performer. And believe me, when he was lost, because he was a member of the music community, rock bands and all of that. And believe me, his funeral was like a state funeral.
Yeah.
It was big. But the thing is, it was during the COVID situation.
Yeah.
I can't understand what mentally drove him to that.
It's a hard thing to empathize with the psychological state of somebody who is suicidal. But we are seeing more legislation, not here, but in some countries, where they're considering psychiatric illness as candidate illness for medical aid in dying. I think a lot of people are of two minds about that, especially because all of our training in the mental health field is to prevent that from happening. I will say that I believe in my bones, and this is not a popular opinion within my field, that depression can be, isn't usually, but can be a terminal illness. Now, that is only the case when somebody has gone through every available option for help and support that exists. The problem is when people don't have access to that help and support. But I have definitely met people who took every antidepressant under the sun, did all the therapy, got ECT, did every extreme intervention, and their depression was intractable, and they ultimately did die by suicide. And for them, perhaps, just perhaps, this could be a viable option. But to get inside of the head of it's not just about empathy. It also, I think, requires a lot of technical training. It is very hard to know what it is like to have a mental illness unless you've been around it a lot, and you've had access to the thoughts and feelings of the people who have it. Yeah.
I thank you for your answer, and my apologies for my emotion.
Not at all.
I'm generally a very disciplined person because of the industries that I'm involved in. I have to be, but thank you.
Of course. And I would argue that being in touch with those emotions is a form of discipline.
I'm just curious, if the medication is so hard to take, why have they not come up with an alternative to drinking something that burns and is icky?
They're working on it, but we have access to what we have access to, And
Venous drugs? No.
we can't, it's illegal.
They have to do it themselves.
Yeah, you have to, people aren't going to inject their own veins with a drug. And they're also not going to know how to do that. Now, maybe in the future, legislation will allow an IV to be placed and then the person to inject themselves. And I think there are people fighting for that. But right now, that would be against the law.
Question from an MD.
About what you were saying, Joel Yeager, his last paper published a rather controversial topic that indeed endorses what you're saying, that we ought to be thinking about assisted dying for psychiatric illnesses. But as a parallel to that also, I think I'm on a campaign that we no longer think of he committed suicide.
Yeah.
No, he died of suicide.
Yeah, I never
and I
used the
think it's
term.
extremely important to think of suicide as a disease.
Yep.
We don't say he committed cancer.
Right.
And I think it's important to distinguish that. The other is two extremely urgent areas of attention. One is the mentally and physically disabled not being able to have access to assisted dying, and that is a shame. Their lives are miserable, either the Alzheimer, who may not ever have further awareness, or the physically, who are condemned to a long, lingering existence.
Yeah, without that 6-month prognosis. Yeah, and those caveats are things that activists are constantly grappling with and writing about. But I'm so glad that you brought that up, because I usually actually do bring that up. If you notice in the quotes, sometimes I'll quote people who would have used the term commit. I, in practice, never use it, and I educate early career mental health practitioners and students, and I really try and push them away from that conceptualization of committing suicide. A, because of what you said, which is beautiful, right? You don't commit cancer. But B, because it is stigmatizing. It sounds like you are committing a crime, right? And it puts you as a perpetrator and not a victim. And so I always use the terminology died by suicide, and I really encourage anybody who I work with to be mindful of that type of terminology as well.
I always found it ironic that it's against the law.
I know, yeah.
You really need to prosecute someone for that.
And sometimes, in some places, and sometimes it is, but definitely aiding and abetting in the commission of a suicide is against the law. And so that's why, again, that's just another reason that access to medical aid in dying is so important. Because think about how many people are asked to be there, to help. Can you be the one who calls, 911 after? Can you help, be there with me so that I actually die? What a scary thing. And so many people beautifully have agreed to it, but they know that they're risking legal action for that. None of that's an issue with the legality of medical aid in dying.
Yeah. Coincidentally, and I may sound like an almanac with this, but 135 years ago today, Vincent van Gogh took his life and was under, was depressive and other things. Okay, a couple more questions.
Big fan of the SGU, by the way, and Skeptic's Guide. I have APOE 4/4s, been going through a couple different studies at UCLA, and you didn't mention anything about mental disease, so like Alzheimer's versus cancers. What are my choices?
It has to do with if you were interested in medical aid in dying, and you were starting to show signs of disease progression, what you would hope for and what you would work with a practitioner on is finding the sweet spot wherein they could reasonably say that you have 6 months or less to live without medical intervention, but that you're still lucid enough and you still have capacity to take the medication. Unfortunately, a lot of people are shit out of luck when they're dealing with neurodegenerative disorders for that reason. So very often people are tasked with the very difficult choice of saying, I want to die with medical aid while I'm still lucid. Because we'd all love to say, the minute I can't anymore, put me out of my misery, not legal.
My problem is, where does that start?
Yeah.
Where is that?
That's everybody's problem. And that's where I think this idea of prognostication, which is an art and a science, don't get me wrong, there are really good tools available to physicians for prognostication. So if you ever get a diagnosis, especially a cancer diagnosis, and you get the bullshit oncologist response of, I don't have a crystal ball, push back. They don't have a crystal ball and they can't tell you for sure, but they have a lot of data available to them. And they can tell you that based on the available literature, individuals in your age bracket, with your diagnosis, with this gene type, with whatever, tend to live on average this long with treatment and this long without. And you deserve to have access to that information. That said, it's a range. So when we're talking about Alzheimer's, right, it's a range. It depends on where you are in the disease progression. It depends on how severe the disease is. If you are, I hate to say it this way, lucky enough that the decompensation happens quickly or is seen to happen quickly, you can probably find a physician who will give you that prognosis of 6 months or less. And that's just what you have to do.
Does it help to have like your end of life choices written down
Absolutely.
ahead of time?
I think everybody should always have an advance directive, always, like regardless of if you're like perfectly healthy, because we could walk outside and get hit by a car right now and we would want the hospital to know what our wishes are. When you have a terminal illness or a life-limiting illness, very often people will also have something called a POLST, which is a physician's orders, which is posted in your home. That way, if an EMT is called, they don't do CPR if you don't want them to. They don't place a line or well, they won't intubate, but they won't do things that you've asked them not to. At the hospital, and this is just a little tidbit that I didn't know until I worked at Cedars, every time there is a readmission to the hospital, the code status resets in the chart. This isn't the case at all hospitals, but at Cedars it is. So every time you get readmitted, let's say that you have your blood counts are low because you're in chemo and you have to go to the hospital to get a transfusion, you're gonna be full code until you tell them otherwise. So it's default to full code, not default to DNAR. And so it's really important that you have that paperwork, that you verbalize with them, that you make sure that your oncologist is updating your chart regularly. Because if you want your code status to be a DNAR, which stands for do not attempt resuscitation, they need to know that because they're going to do what they have to do legally, right? It's a bummer, but that's the way that it works. So yeah, when it comes to that 6 month or less prognosis, it's not set in stone. It's not science. The law is set in stone. Physicians know that there's no way to know. Some people could live a year even though they think it's 6 months. Some people will die within a month. It's statistical. It's probabilistic. And so work with your physicians. Make sure they know your wishes. Start having those conversations early. And you can work together to figure out if and when it's time. And unfortunately, this is not the one, because we've talked about mental health as well, but this is one area where there's a lot of controversy. Or it's not very clean, or cut and dry.
Okay, last question.
Okay, this idea of donate my body to science, go to medical school, give my cornea, whatever. How does that, like, what if I wanted my parts that were left of me to be put to use?
Yeah, I think that you can still donate if you utilize medical aid in dying, but you're probably not going to be a whole organ donor anyway, because you're probably not a candidate if you're dying from one of the terminal illnesses that would give you legal access to medical aid in dying. Very often, whole organ transplantation, lungs, heart, liver, those are things that happen in hospital with individuals who are on heart-lung, right? Like they are brain dead or they have, been in a terrible accident. They're not going to be resuscitated, but they're able to be on heart-lung machine and still get perfusion to those organs. That said, when we donate our bodies to science, we have lots of options, right? There is the medical component. There's the corneas, there's the skin, there's the tissues that are really necessary. There's cadaver bones, there's things like that. But there's also, if you've ever read Mary Roach's Stiff, if you haven't, I highly recommend it. Yeah, she's the best. She talks about all the cool things that you can be used in the body farm. You can be used for surgical students to practice. So many uses that go to help so many people, even if there's a toxic drug load in parts of your body or your organs aren't healthy enough to go into a living transplant recipient. So, there are organizations that you can work with, like whole body donation organizations that you can work with. You can get that put into your your living will. You can make sure that, the most important thing other than having things documented, which is important, make sure that the person who is your healthcare proxy, which is identified on your advance directive, or the legal healthcare proxy that would happen without documentation, which would be your next of kin. So it's your spouse if you have a legal spouse, it's going to be your children if you have legal children, or your parents, I think in that order. But make sure they know your wishes and that they will respect your wishes. And if you feel like they won't, document, and make sure that that's all very, very clear in case an ethics board has to get involved. Because in the heat of the moment, the paperwork doesn't always make it, and it doesn't always matter. What matters is that the people that are there and showing up can make decisions and say, this is what mom said she wanted. I know without a shadow of a doubt, this is what we're doing. And they'll follow those orders. Whole body donation organizations are usually private, so keep that in mind. Do your research, pick one that you like. One thing that they're legally not allowed to promote or advertise, because it's like a little bit dark, is that you get a free cremation out of it. So they will send you, cremation's expensive. It can be like on the cheap end, like $800 or $900, but they will send you very often overseas. There are individuals within the organization whose job it is to track where you are and to keep good records. Whatever is left of you, because you won't all last, but whatever is left of you will be cremated and sent back home. And very often they'll include a lovely letter for the loved ones that will say something like, so-and-so contributed. They won't give you details, but they might say, so-and-so contributed to heart disease research.
Why overseas?
That's where the market is.
We took some of my uncle's ashes. He was a Chicago Bears fan all his life. And we dumped them at gate 00 at Soldier Field.
I love it.
In Chicago. So don't forget those fun rituals. Cara, thank you so much. Excellent talk. We appreciate all that information. Everyone else, we have the great Professor Anthony Pinn is coming next month and giving a talk. And we've got a bunch of great stuff coming up in the fall. Thanks to Alice and Dave for helping out today at the front end, and Sean for doing tech. Give him a hand.
Hey, Sean.
And that's it. See you next time.
Thank you.